morning, everyone.
Nobody's smiling. Good morning. Why are you looking too serious? Okay, so you're welcome to today's symposium, the 8th Abuja Cardiovascular Symposium that is being hosted, as we all know, by the CardioCare Multispecialist Hospital, Abuja. My name is Dr. Eze Muna, family physician, and with me today is
Dr. MARIAM, INUWA.
So the topic we're going to present is on hypertension. Dr. Melvin mentioned that hypertension, you mentioned hypertension in internal medicine. I would say that hypertension cuts across all specialties. It can be O&G, family medicine, especially because most of us at the primary care level are always seeing hypertensive patients on a daily basis. So the essence of this presentation is for us to know what to do, what not to do, how to diagnose and how to manage. So hypertension is the most important modifiable risk factor for all-cause mortality and also cardiovascular disease mortality and morbidity. As we all well know, it's quite common all over the world. We have over 1.3 billion people living with hypertension, and most of these people live in low and middle income countries such as ours. Nigeria stands at about 33% of people with hypertension. So this is to emphasize the importance of this topic.
So we all know how hypertension is so important because we get to see patients that have high blood pressure, and we know how, for whatever reason, either they're so reluctant to start medications because they feel like, why will I take drugs for the rest of my life? They can't fathom that, or they're on medications and it's not well controlled still. So the whole idea is for us to know what hypertension is all about, know how it's properly diagnosed, and how we can manage and treat properly with good follow-up.
Slides are not yet up, but we'll just keep talking. So we'll have a brief outline. So we'll start with a brief introduction. We'll talk about diagnosis, cut-offs and terms. We'll talk about proper measurement of blood pressure. It's not just enough to diagnose and then prescribe medications. We should be able to measure this blood pressure, to be able to get accurate readings. Also, we'll talk about history and examination. We'll talk about the 5-step approach to diagnosing hypertension, which is Dr. ETC. It means diagnosis, risk stratification, education, treating to targets, clinic follow-up. Then we'll talk just briefly, about some special considerations like hypertensive crisis, hypertension in pregnancy, and resistant hypertension. And then finally, when to refer accordingly. So we have a case presentation here, which Dr. INUWA will briefly talk about.
Okay, starting with the case presentation. This is a patient that came to CardioCare, a 34-year-old para 2 plus 02 alive, who gave birth 3 weeks ago, presented in the emergency with a home blood pressure that was elevated and she was anxious. She didn't have any complaint. She just checked her blood pressure at home. It was elevated. She came to the emergency. There was no chest pain, no difficulty in breathing. She didn't have any other complaint. She's always had high blood pressure for about 2 years, and because she was pregnant, they changed her medications to TABS, Aldomet, Labetalol, and she's been regular with her medications. So pregnancy, delivery was uneventful. On examination, young lady, not pale, anicteric, acyanosis, afebrile, neopedia edema. On cardiovascular examination, the pulse rate was 72 beats per minute. It was normal volume and regular. The blood pressure was 240 over 120. The heart sounds were 1 and 2. So this is ECG. Later on, we'll talk about ECG, so that anytime we see ECG, it doesn't sound strange, it doesn't look disturbing. We know what to do, because as medical practitioners, we should know how to report ECGs. It guides us on how to manage our patients. So she came with this ECG that just showed the normal sinus rhythm. There wasn't anything significant. The whole idea of this presentation is, what do we do when we see high blood pressure? You know, we're going to look out for hypertensive-mediated organ damage and many other things. So for this guest, for this patient that presented, the ECG was normal. So now, what is the correct answer? So what do we think? Is this case that of hypertensive emergency? Should we give sublingual nifedipine? Should we crash the blood pressure? Should we give oral antihypertensive? Or just give Lesotan and tell the patient to come back in 2 days' time? We see a lot of that. People will say, oh, she's anxious, she's worried. She just gave birth. She's struggling with breastfeeding. She needs to sleep. So the blood pressure is not the real picture. Let's just give her Lexotan to relax her, the BP will come down. So with 240 over 120, please, what do we do? Can we answer?
Please, you can join our polls at www.cardiocare.ng/polls. That's cardiocare.ng/polls, POLLS, so that you can answer interactively.
Are we almost there so that we don't waste too much time? Or we could even come back, because the whole idea is to have something, let's start thinking about these things, so that at the end of the presentation, we should know what to do. So we can see hypertensive emergency, okay. Okay, all right. Seems like hypertensive emergency has the highest. Wow, we need this lecture.
Yes, we do. We really do.
So by the time we're done, the whole idea is that we would then know the answer to this question.
Yeah. Okay, so a brief introduction. Definition of hypertension. It is defined as a level of blood pressure at which the benefits of treatment unequivocally outweigh the risk of treatment. The office systolic blood pressure values are greater than or equal to 140 millimeters of mercury, and or diastolic blood pressure values are above 90 millimeters of mercury. Now, that first pointer that says the benefits of treatment outweighs the risk of treatment, we'll talk about it down the line, because most patients will ask you, why do I need to take these medications? Are there side effects? What about the side effects of these antihypertensives? So that would help guide us on how to answer. So persistently high blood pressure in systemic arteries is the hallmark of hypertension, which is the most important modifiable risk factor for all-cause and cardiovascular disease morbidity and mortality globally. It may be primary, which may develop as a result of a variety of environmental or genetic causes, or secondary due to renal, vascular, and endocrine causes. Primary essential hypertension accounts for over 90%, 90 to 95% of adult cases, and secondary takes about 2 to 10% of cases. So this chart talks about how high blood pressure kills nearly as many people worldwide each year as all infectious diseases combined. We can see that high blood pressure takes up about 9.4 million global deaths per year. That's mind-blowing when you compare with acute respiratory infection, diarrhea disease, AIDS, diabetes, and so on and so forth. So, that's quite significant. Then we'll talk about the second chart that talks about the percentage by which deaths from cardiovascular diseases could be reduced if specific risk factors were brought under control. So imagine that we all know what to do in our clinics when we see patients with hypertension. What it will result in is about 55% of cardiovascular deaths eliminated. So we all have a role to play, regardless of your specialty, because hypertension cuts across every single specialty. So that's very important to also know.
So we'll be discussing what are the cutoff terms for diagnosis of hypertension. So we should know what the cutoff terms are to make a diagnosis of hypertension, and the cutoff terms to know control. So when we talk about making a diagnosis, the values are different from where we want to control, as if this person is on hypertensive medication, what is their target? So their target is different from the diagnosis value. So we'll go through it so that we are clear on it. So this is hypertension diagnosis based on the European Society of Cardiology, and then we can see the different grades. These different grades are so important because as we go along, we'll know what to do at the different points. In the sense that by the time you're seeing somebody with high normal, don't just look at it and say, oh, it's not yet 140/90. It's high normal. We can still do something at that point, like lifestyle modification, you know. Then when we talk of grade 1 hypertension, that's it. And once we see something greater than 135 and 85, you know that it's not well controlled or the person has hypertension. Then there's what we call the ambulatory blood pressure monitoring. We have it in CardioCare, we have a lot of it. I'm sure some of your centers do have it. And if you know that your patient will benefit from it, you can always refer to us to get it done. So the whole idea is you're putting on the ambulatory blood pressure monitoring for 24 hours to pick up blood pressure. It helps us a lot. It shows us so many things. It tells us whether we are dealing with white coat hypertension, max hypertension, you know. So it tells us good control, what happens at night, you know. So it's a very, if you can afford it, then it's very good to have the ambulatory blood pressure done. So what are we looking
And I must add, sorry to cut you off, I must add that the guidelines, that is the European Society of Cardiology, also supports, you know, the use of out-of-office blood pressure measurements for control, for monitoring of the patient's progress while on antihypertensives. So let's also form a habit of telling our patients to keep a home blood pressure monitoring. Sometimes it might not be economically feasible. Ambulatory blood pressure monitoring is not cheap, but we can actually do with self blood pressure monitoring and records, which can guide management and control.
So it's advised that all our hypertensive patients have their own BP monitors too at home, so that when they're having any funny feelings, they can check their blood pressure. All this reading of, oh, the reasons when they say, oh, it's only in the hospital, the only way we can prove it is when they show us their reading at home, what their values are at home. That's the only time we can tell what we're dealing with. So even in those that are hypertensive, you also deal with things like whoosh, much, such. You know, those are those that have high blood pressure, but either not well controlled. So when we talk of the white coat uncontrolled hypertension, they are hypertensive, but the only issue is that in the hospital it's elevated, at home it's normal. Or you're talking of the max, they're hypertensive, but in the hospital it's normal. When they go home, it's abnormal. Or those that just have sustained both at home and the hospital, they have high blood pressure. So it's always good to classify your patients where they belong, because it guides you on how to manage them. Those you restrict about BP control, you know, and being able to make a decision about either change of drugs or you up titrate and all. So this is the same thing. Yeah, so it's always also very important to rule out secondary hypertension, because we see young adults coming down with high blood pressure. We see a lot of that in our clinics. So don't just get carried away with the numbers. You know, it's not just all about the numbers. That's why we talk about doing investigations to see if, what are we dealing with? We know, yes, there are more cases of primary hypertension, but we shouldn't forget their secondary, because those things have to be addressed if we're able to tell what is the cause. So when you're seeing a young adult, we've seen people in their 20s, 19-year-old, 18s, you know, yeah, with high blood pressure, you know. There was even one recently, she was preparing to go to school, she just came for a checkup. Although she was on the big side, in short, when she told me her age, I was surprised. I didn't even know she was quite young. She was still a teenager. And she had high blood pressure, you know. So don't just feel like, oh, it's just the numbers, just give them drugs. No, we need to know. And if we don't ask questions, if we don't take proper history that would direct us on the type of investigations to do for them, we might miss out that secondary hypertension that has a cause that can be managed and treated. So
for secondary hypertension, there are several causes of secondary hypertension. Number one on the list is the obstructive sleep apnea. How many of us, when clerking patients, try to ask questions, to elicit if the patient has obstructive sleep apnea or not? You can raise your hand. No one? Okay. So it's quite common, and there are several ways to actually elicit that. Using a tool, what we call the stop bang mnemonic, you can look it up. It talks about snoring, T for tiredness, O for observed apnea, P for blood pressure, then you have S for the gender, and then you have B is blood pressure, H greater than 50 years, and then you have what we call the G for gender. So just look it up. Stop bang is something that we can use. So if you have a patient that is overweight with a BMI above 30, you have to think about it. Neck circumference in men above 43 centimeters, 17 inches. You have to also think about it. So it's something that's quite common, and it can actually cause secondary hypertension. Others are renal parenchyma disease, renovascular diseases like atherosclerotic renovascular disease. Then we have primary aldosteronism, pheochromocytoma, Cushing's syndrome, thyroid diseases. We have hyperparathyroidism, we have coarctation of the aorta, and then some of those rare causes, like the Liddle syndrome, the Gordon syndrome, the Geller, the glucocorticoid remediable hypertension, which usually presents with low potassium. Then we'll briefly talk about measuring blood pressure. Now, measurement of blood pressure is very, very important. If we were to make a diagnosis, we look at the ESC classification of hypertension. So how do we know whether the patient has stage 1, stage 2, or 3? So being able to take accurate measurements is very vital. First of all, when the patient comes into your consulting room, don't be in a hurry. Despite a busy clinic, don't be in a hurry to just start. Okay, madam, please, good morning, sit down. Let me check your blood pressure. No. Try to establish rapport. Within that period of about 5 minutes, the patient is calmer. Make sure that the environment is quiet and conducive. And then 3 blood pressure measurements should be recorded, 1 to 2 minutes apart, and then average the last 2. Now you can take several other readings if there's a difference of above 10 millimeters of mercury. Now, additional measurements may have to be performed in patients with unstable blood pressure or atrial fibrillation, in whom you have to use the manual auscultatory methods for that, especially in AF. Then use a standard bladder cup, 12 to 13 centimeter wide and 35 cm long. And then for most patients that have maybe larger arm or thinner arms, you have to use the appropriate cups for that. Then the cup should be positioned at the level of the heart, with the back and arms supported to avoid muscle contraction and the isometric exercise dependent increase.
Okay, so we'll try to be fast and run through some things quickly. So we should just remember that when we're checking our blood pressure, it's not the first reading you're going to document. Take your time. There's the second and the third. That first one, it gets still anxious and all of that. So I guess it's still worried, what's the blood pressure? So it's the second and third you want to take an average of. And then it's important if you're using the mercury stick, then to know the sounds to listen for. We'll have the slides, so just quickly move past all of this. It's very important to know that you should also ask if they've just had caffeine or done any exercise recently. A lot of us drink coffee a lot, so we need to ask these questions. They should have empty bladder. They shouldn't cross their legs. Sometimes they feel so comfortable, you're not even looking at them, their legs are crossed. So we don't want crossed legs, ensure the coffee is appropriate, and then it's a quiet room. So please, we have some sweets around, there's some sweets around. We just want, just little groups can just gather around where the sweets are. Let's just see how we can get it done properly. Please, Mr. Sam.
Okay, so while we're doing that for the sake of time,
Dr. Ada, please, do you have the sweets available?
Yes, ma'am.
Please, can we just put them like two, just scatter them around. It's just for us to just demonstrate, people will watch what you're doing. Please, Dr. Ada, Dr. Ene, Dr. Taiwo, please, if you guys are around, please help us out. You don't need to bring it to the front, just put it in the middle somewhere. Let people just gather and see how it can be done, and then people will watch to ensure you're doing the right thing.
so when checking your blood pressure, make sure that the back is supported, the legs are uncrossed, and the 2 feet are flat on the ground. While checking them.
Sorry, there could be volunteers from the group, just anybody. Don't be worried. You shouldn't be scared that we're going to know where your blood pressure is. At least you get an opportunity to check the blood pressure. So while that is going on, we'll just continue. When we see you're ready, we'll go back to it. So remember that it is important to have the appropriate calls. So in your consulting room, you should have different calls. If you're seeing an obese person, you should have a bigger call for that person. This is what it's all about. At least the diagram shows us the direction of the tube and all. We'll have the slides, we can go through it. So we just want to quickly go past this. I don't know, the speaks, are people, sorry? They'll say, please, we just need volunteers. Somebody will check blood pressure, somebody will be seated on the seat. And then people are just watching to ensure we're doing the right thing.
You look too serious, please. Relax.
Because sometimes we think we know what's the right thing to do, but we're not getting the blood pressure really properly done. So it's time for practical demonstration. Nobody's standing up. We have to speak. Where's Dr. Ene? I saw her just some minutes ago. Where's Dr. Taiwo? Dr. Ada? So it's very important to do history and examination, because as we said, it's not just all about the values. We need to know if there are other organs involved. And this is a long list when we're doing history. It's very important to know, okay, is there any difficulty breathing, chest pain, leg swelling, dizziness, headaches, has the person had a stroke before, or having features of a stroke, or signs of renal involvement, So it's very important to go through all of this. You want to know if the person is obese, smoking history, alcohol, if there's a family history, all these increases their risk factors and guides you to know how to manage also. And then going to the examination, we should remember that depending on what we find from the history, it's important to calculate the BMI, know the waist circumference, know what is normal and what is abnormal, and then check the eyes, you're doing your fundoscopy, if you don't have it in your centers, you're sending them to get it done, because that's just a retinopathy, and that will guide us too. So that even if these people have what seems like a normal blood value or high normal, you know they need treatment because they are having end organ damage. The only way we will know they have hypertensive end organ damage is by checking these things. So our examination is important. We need to examine properly.
So talk about diagnosis. Thank you, sir. So we'll talk about the 5-step approach very fast because of short time. ETC is a unit that can guide you in the clinics. Talk about diagnosis for D. So you can get diagnosis. This is what we are stressing on blood pressure measurement. So you have to get your accurate blood pressure measurement to be able to classify or risk stratify the patient accordingly. So if there's elevated blood pressure or you suspect that, and you have an office reading of greater than equals to 160 over 100 millimeters of mercury, if that is yes, then immediately we make a diagnosis of hypertension. But if no, then you have to repeat the office blood pressure, do a daytime ABPM, 24-hour ABPM or home ABPM monitoring. Then you can make your diagnosis following this chart. That will guide you when you go through it. So why do we investigate? We want to find and alleviate hypertension-mediated organ damage. So in this, you have to do some vital investigations, such as an ECG and echo, kidney function, uric acid, and so on and so forth. We also want to risk stratify this patient, identify other cardiovascular risk factors like diabetes, obesity, and the rest of them. So what is your first line for all? Regardless of who the patient is, you must do a urinalysis. I'm sure we can go over this in our center: the kidney function, fasting blood sugar, HbA1c, lipid profile, full blood count, ECG, echo, and then calculate the BMI. So always ask the nurses to weigh the patient and check the height, so you can get this as well. Then second line, for some people, depending, now you have to personalize this, it's not for everyone. When you have to do a renal artery Doppler ultrasound, especially for patients less than 40 years of age who are hypertensive, the uric acid levels, sparrow function tests, etc. So for the risk assessment, now if there's an elevated blood pressure when you've confirmed after 2 office readings using a standard approach, you have to look at risk, assess the patient's risk using maybe the atherosclerotic cardiovascular disease score. You can also use the score 2 or the score 2 up, etc.
So emphasis on there must be 2 office readings. So when you're seeing someone with high blood pressure, you might not do anything about it at that time, depending on the value you're getting. But once it's severe hypertension, that's if they're dealing with grade 3, that's 180 or 110, you know that yes, that person needs to have antihypertensive at that setting. But if you're dealing with maybe grade 1, especially grade 1, you see all those 144 over 90, 91, 92 kind of, you know that, do your okay. So if this is somebody with grade 1 hypertension, then you know that yes, you do your investigations, and then you have to check again, and then if the person still has sustained blood pressure, because remember, sustained high blood pressure is what we are looking for, not just the one-off reading. We talked about all of this. This is another case, but we'll just, you have the slides, you can go through it. But simply somebody that came with ECG showing LVH. We'll know how to do that, and there's a question to it. We're already running out of time, so we're trying to be fast so that we can go through the important things. So we should remember that for hypertension, the bedrock of hypertension is education. We can't overemphasize this so much. As in, education, we need to counsel our patients. If we're able to counsel them, they would understand that they should always take their drugs. Some people will come and tell us that when the blood pressure is really normal, they stop their drugs. But when they're counseled properly, that won't happen. So we should counsel them on medications, what it's all about. And anytime they come on follow-up, we should be ready to do investigations for them, so as to monitor them in case they come up with any hypertensive end organ damage that maybe initially they didn't have, but later on they're not having. We need to counsel them on lifestyle modification. They need to, if they're obese, they need to lose weight. They need to see the dietitian to counsel them on diets. They need to exercise. What we always encourage is about 150 minutes of exercise in a week. That is 30 minutes, 5 times a week. So even if it's fast walks, jogging, running, whatever they can do, it's always good to exercise.
And I must add that most of us don't have dietitians in our center, so we can actually do this by counseling on increase in fruits and vegetables because they are rich in potassium and magnesium. So you mustn't really send to a dietitian if you don't have it available. You can still tell the patient what to do.
Or you refer to CardioCare. So they remember to treat the target. Remember, our target is a blood pressure less than 130 over 80. The only exceptions are for elderly people rated than 65 years old, when we say, okay, our target should be 140 over 90. But for anybody that has high blood pressure, remember our target is 130 over 80. Less than that. So remember the lifestyle modification. They're about to take my